Hi, my name is Heather Duncan, and I'm going to be giving my presentation on autism spectrum disorder. Thank you. This is just a brief history of autism. Autism has a rich history. This is just scratching the surface to give you some context. In 1747, this is the first evidence we have that's handwritten in a legal document that someone could possibly have autism, even though people with autism probably existed before that. In 1747, a Scottish lawsuit gives us information to believe that the brother of Hugh Blair petitioned for the annulment of a marriage due to his incapacity to marry. Reported deficits in normal social behavior, abnormal gaze, tactlessness, and repetitive phrases. His brother collected feathers and stickers. He was described as lacking common sense and suffering from a silent madness, as the paperwork says. Many believe that this person did actually suffer from autism. So this proves that autism has been around a lot longer than it was actually diagnosable. If we fast forward about 200 years to the 1940s, we have two doctors, Dr. Kanner and Dr. Asperger. Both of them were studying autistic children. They didn't know they were autistic at the time because that word didn't exist, but Dr. Kanner is from Austria. We're going to focus on him first. He's right here. And he moved to America to study children with autism. In 1943, he published Autistic Disturbances of Affective Contact, and he coined the word autism, which is a basic desire for aloneness and sameness. He differentiated between the schizophrenic and the feeble-mindedness from autism, and he wrote The Nervous Child. Before, people with autism were clumped together into different categories, maybe intellectually delayed or schizophrenic. A genetic link he proposed was probable. He challenged the common belief that just bad parenting caused autism. Now, Dr. Asperger was studying the same stuff in Austria at the same time. Coincidentally, George Frankl, Asperger's chief diagnostician, moved from Austria to America and was hired by Leo Kanner in 1937. So some of their research might technically overlap a little bit. Hans Asperger in 1944 was studying autistic behavior, and he was in Vienna. He was studying and finding the same thing that Dr. Kanner was finding. So that's kind of where we get the term autism and the term Asperger syndrome. Asperger syndrome is technically kind of the same as autism, but under a different name. They were studying the same disorder, some would argue. That is why Asperger's is not in the DSM-5, and we'll talk about that later. Lorna Wing was actually the first person in 1981 to state that Asperger's is a syndrome that we now know, and we now know that it is now known of. It appeared in the DSM-3 for the first time in 1980. In the DSM-4-TR in the DSM-5, there's huge changes whenever we look at autism spectrum disorder. In the DSM-4-TR, we have pervasive developmental disorder, and under that we have autistic disorder, Asperger's disorder, pervasive developmental disorder not otherwise specified, Rett's disorder, and childhood disintegrative disorder. Well, with the revision of the DSM-5, they clumped together autistic disorder, Asperger's disorder, and pervasive developmental disorder, and not otherwise specified, and they put it in the category of autism spectrum disorder, and the term spectrum was added. Rett's disorder and childhood disintegrative disorder were no longer in the DSM. These are the DSM-5 diagnostic features. For autism spectrum disorder. Persistent deficits in social communication and social interaction, currently or by history. The deficits would be in social-emotional reciprocity, nonverbal communicative behaviors used in social interaction, developing, maintaining, and understanding relationships, Also, restrictive repetitive patterns of behavior, interests, or activities as manifested by at least two of the following, currently or by history, stereotyped or repetitive movements, motor movements, the use of objects or speech, insistence on sameness, inflexible adherence to routines, ritualized patterns of verbal or nonverbal behavior, highly restricted fixated interests that are abnormal in intensity or focus, hyper or hypoactivity to sensory input or unusual interest in sensory aspects of the environment. Symptoms must be present in the early developmental period, but may not be noticed until the social demands require more than cognitively capable. These are the diagnostic features continued. Symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning, and these disturbances are not better explained by intellectual disability or by global developmental delay. Severity. This is kind of where autism spectrum disorder differs in the DSM-5, because now we look at two things to determine the severity: social communication and restrictive repetitive behaviors. So here we have a spectrum, and if you think on one end we have level 1, which means requiring support. They are not 100% independent. To level 2, requiring substantial support. To level 3, requiring very substantial support. This might be a person who is nonverbal or stems a lot. Here is a table that's listed in the DSM-5, kind of differentiating the level 1, level 2, and level 3 based on social communication and restrictive repetitive behaviors. You can find this in the DSM. Associated features and conditions. Intellectual and language impairments are often present, early and even later on. Uneven profile of abilities. A person might have a high IQ but is unable to have a cohesive conversation with a peer, a teacher, or a parent. Motor deficits include clumsiness, odd gait, walking on tiptoes. Self-injury and disruptive challenging behavior can be present, and it is possible for someone with autism to experience catatonia. They can be catatonic, but usually that happens in adolescence and is very rare. Prevalence and risk factors. The etiology. We look at two areas of etiology here: environmental and physiological. First, environmental. These things can affect the outcome: advanced parental age, low birth weight, fetal exposure to valproate. Valproate is a medication that is taken by women who have epilepsy or have bipolar. Genetic or physiological etiology. Heritability is from 37% to 90%. In twin studies, here's my twins, there's fraternal and identical twin studies. Fraternal twins show a 37% chance that if one twin has it, another one might. Identical twin studies have been up to 90% that if one twin has it, the other twin will. But this is not 100%, so we cannot say that it is 100% physiological. 15% are known to have related to a genetic mutation possibly, and maybe potentially be polygenetic. Prevalence. According to the CDC and the ADDM network, in the year 2000, 150 children were diagnosed with autism. In the year 2010 and in the year 2014, it is reported that 1 in 68 were diagnosed with autism spectrum disorder. This is a huge hike. Autism spectrum disorder is 4.5 times more common among boys than it is girls, 1 in 42 boys and 1 in 189 girls. Autism spectrum disorder is reported to occur in all racial, ethnic, and socioeconomic groups. Course and comorbidity. The course of autism is usually diagnosed in early development. The earlier the diagnosis, the easier it is to implement intervention. 12 to 24 months is optimal. The first symptoms include a delay or loss of language development, decrease or absence of desire for social interaction, and atypical forms of play. For instance, they might carry around a car, but they never play with the car. Or they might line up the cars in a row, but they never actually move the cars. Early diagnosis is so important, and oftentimes what you encounter are parents that are in denial about their kids' situation. And so what you have is sometimes parents cater to the needs of their autistic children. They don't put them in social interaction, they cater to their desire for sameness and things like that. Few adults with autism live an independent life. Those who do have superior language skills, high intelligence, and are at a high level of functioning. A later diagnosis is made oftentimes because the family of the person with autism spectrum disorder has kept them from social interaction and catered to their desire for sameness. Autism spectrum disorder is a lifelong diagnosis. It is static, it does not wax and wane, but therapy is a helpful tool for those with autism spectrum disorder to assimilate to societal demands. It helps them also with school and occupation. Comorbidity. ADHD is oftentimes duly diagnosed. Epilepsy is oftentimes duly diagnosed. Intellectual impairment and structural language disorder should be ruled out using their own criteria. Developmental coordination disorder, anxiety disorders, depression disorders, they can also be comorbid. Also, people with Down syndrome have a higher risk of having autism also. GI problems are 4 times as prevalent among autism spectrum disorder population, and several studies have found that children in adolescence with autism spectrum disorder are more likely to have sleep problems than children without developmental disorders. Children with autism spectrum disorder have been found to have shorter sleep duration per night than typically developing children and have frequent night awakenings. It's important for kids who do not speak to watch and pay attention to observable signs such as eating and sleeping, since they cannot express their needs. Prognosis. The quality of life and well-being of a person with autism is dependent on the support from the family, and for that very reason, education and support for autism spectrum disorder families need to have priority in the plan for intervention. Lack of social communication may impair learning. Insistence on routines, aversion to change, or sensory sensitivity may interfere with eating and sleeping and may make self-care extremely difficult. So these are things that as a person with autism grows and matures, these are important things to keep watching and help them with. During adulthood, individuals may have a difficulty acquiring independence due to their rigidity. Functional consequences of old age is unknown. Social isolation and communication problems are likely to have effects on older adults with autism spectrum disorder. Forms of treatment. Cognitive behavior therapy is most commonly used with persons with autism spectrum disorder. So what you can do is curb their tendency to resort to self and to help them be more open to change. The goal of intervention is to optimize the functional independence of the individual with autism spectrum disorder by minimizing the core autism spectrum disorder features. Another goal of the intervention is to reduce restricted interests and stereotypic behavior and eliminate maladaptive behavior. No medical treatment, however, can eliminate autism spectrum disorder symptoms, but medical treatment may be necessary to reduce symptoms from comorbid psychiatric disorders. That is the end of my presentation. Thank you for listening. Enjoy.